So we will start our lecture with the structure of one of the very important elements of the respiratory tract, that is pharynx. It's a fibromuscular tube, and I will give an example. How does a pharynx look like? Like if in case of deep sea divers, they put an oxygen mask in front of their nose, the antenares, and they cover it up for the supply of oxygen. So this is the mask, the mouthpiece of the mask, and my wrist is the tube through which the mask is attached to the oxygen cylinder. Okay? So now picture this mask has been placed not in front of the face or not in front of the antenares, but rather in front of the posteriors, okay, which are these, right? So it's like this. The pharynx looks like this. So it resembles a short garden hose, okay, with the mouthpiece and a tubular structure. And I have mentioned that this tube, fibromuscular tube, is anteriorly deficient. Its anterior wall is not there because it cannot be. It is providing air, a passage down to the larynx or the other respiratory tract in the lower region. Okay, so the anterior wall has to be deficient. Okay, right. Keeping this architecture in our mind, that it's like an oxygen mask which has been placed instead of antennae, has been placed in front of the posteriors or the choanae, and it's covering up the nasal cavity, the oral cavity, and then it is descending down into the neck, and in front of it is the larynx. Okay, now we have this concept in our mind, and now we'll move on to these board drawings, just to understand the architecture or structure of the pharyngeal wall. Okay, I have mentioned that the pharynx has a fibromuscular framework. Okay, you can see this is the base of the skull, base occiput. It's actually this part of the sphenoid bone, the central part or basilar part of the sphenoid bone, on which a thick fibrous band, which is known as the pharyngo-basilar fascia, that has been attached. Okay, that has been attached, and it just let me show you the line of attachment. If you are able to see on this model, although it is all white, but you have to pay attention to, these are the choanae or the posteriors, and the pharyngo-basilar fascia, which is nothing but a tough membranous sheath, right? That's why it's known as fascia. It's giving us attachment to the sharp border of the medial pterygoid plate, because these are the lateral pterygoid plates. Remember, the medial pterygoid plates, and then on to this is the pharyngeal tubercle, or the central elevation of the base occiput part of the sphenoid bone, and then all around. Okay, and if I put it back, you can see that this is the attachment of the pharyngo-basilar fascia. I hope that you're able to see that it is giving attachment all around like a U shape. Okay, and it's allowing the passage of the air, inhaled air, down towards the larynx. Okay, pharyngo-basilar fascia, it's making the topmost part of the pharynx, and we are looking at the pharynx from behind. This is the posterior view of the pharyngeal wall. Its posterolateral wall can be viewed. An anterior wall is missing. Okay, then this central thickening is actually the pharyngeal ligament or the median ligament. Okay, it's also known as the pharyngeal raphe. because by definition a raphe is the point in the muscle. It's an elevated region, central region of the muscle, where multiple muscle fibers from different angles are coming and giving their insertion in a crisscross fashion. So it provides further strength to the tube. Okay, so we can also call it pharyngeal raphe, or the median ligament, or the median pharyngeal ligament. Okay, so it starts from the base, the occiput, and it goes down till the end. All right, so here we can see three main muscles which are known as the pharyngeal constrictors. They are predominantly making the posterolateral wall of the pharynx. There is a superior constrictor which takes origin from, let me go back to my what you call the specimen, the bony specimen. As you can see, there is this mandible, and this is the pterygoid plate, okay, the lateral pterygoid and the medial pterygoid plates. So there is again a raphe which is present in between the mandible and the medial pterygoid plate. It's from this raphe, the pterygomandibular raphe, is taking origin the fibers of the superior constrictor muscle. So this superior constrictor muscle is the shortest among all three constrictors, but it has a very broad origin, okay, and it just slopes medially from lateral to medial, and it is lying just below the pharyngobasilar fascia, okay, or the membranous part of the pharynx. Just below it is the curvy fibers of the superior constrictor muscles which are occupying this gap. Okay. Then we have a right superior constrictor and a left superior constrictor, and then at the superior constrictors, the lower margins of the superior constrictors are covered by this obliquely running fibers. They are the fibers of the middle constrictor muscle. Okay, the middle constrictor muscle on both sides is taking origin mostly from the hyoid bone, the body and the greater horn of hyoid bone. So it must be at the level of neck, below the mandibular level, because this is up at the level of mandible. This is at the level of base of skull. Okay, so we are going down step by step. So the middle constrictor on both sides is taking origin from the two horns of the hyoid bone and also from the body of hyoid bone. And the fibers are blending in the raphe, okay, from both sides. Then the last but not the least, or the superiormost, the outermost large band, which has some obliquely running fibers and also some transversely running fibers down there, is the inferior constrictor. This whole band is the inferior constrictor, and I have mentioned the two elements of inferior constrictor. The inferior constrictor is taking origin. I would rather ask you to pay attention to this drawing as well along with it, because this is the posterior view and this is the lateral view. So as I said that the superior constrictor fibers are taking origin from the pterygomandibular raphe mostly. Then the middle constrictor fibers are taking origin from the body of, this is the hyoid bone. This is the styloid process. The stylohyoid ligament, this green colored thing, is representing the stylohyoid ligament. In this region would be the pterygomandibular raphe, through which the fibers of superior constrictor are taking origin. Then the middle constrictor fibers are taking origin from the body and the greater horn of the hyoid bone. Then here you can see this is this green colored structure or membranous sheet is the thyrohyoid membrane. Okay, we'll be talking about these membranes in detail when we'll discuss the laryngeal anatomy. Okay, so this is the thyroid cartilage. And we know that there is a thyroid oblique line on the thyroid lamina. From that oblique line, the obliquely running fibers of inferior constrictor are taking origin. And again, they are blending or inserting into the pharyngeal raphe, which is running in the midline. The other side, from the other side, the other band, oblique band of inferior constrictor would be coming and blending. And then the lowermost fibers of the inferior constrictor, as you can see, are not oblique, they are transverse or circular rather. Okay? They are taking origin from the lamina of the cricoid cartilage, which is the lowermost cartilage of the laryngeal apparatus. Okay? So we call these obliquely running fibers of the inferior thyroid as the thyropharyngeus muscle, although it's one muscle, inferior constrictor, but we have named them according to their origin. Thyropharyngeus, and then this is the cricopharyngeus or cricopharyngeus muscle. Okay, the two thyro and cricopharyngeus muscles together will form the inferior constrictor muscle. All right. How these constrictors, the name is indicating that what they are doing. Their main action is constriction. Okay, contraction or narrowing down of the lumen of the pharynx, so that the bolus of the food, when it arrives in the pharynx, the constrictors start contracting and they will be propelling the bolus down to the esophagus. Okay, this cricopharyngeus muscle, here is the esophagus, and we know that the esophagus, just like the rest of the gastrointestinal tubular wall structure, there is an inner circular band of the muscle and then outer longitudinal band. So the inner circular muscles of the esophagus are blending, or rather the cricopharyngeus muscle is blending with the inner circular layer of the esophageal muscle. And it is also acting like the superior constrictor of esophagus. We have an inferior constrictor down at the level where the esophagus is entering the cardiac end of the stomach after crossing the diaphragm. That is the inferior esophageal sphincter, while the superior esophageal sphincter is nothing but the circular fibers of the cricopharyngeus muscle. And keep in mind that this sphincter or the cricopharyngeus fibers, they are always in a state of contraction while we are breathing air in and out. Okay, it does not allow the air, which is actually passing through the nasopharynx, oropharynx, and then to the laryngopharynx, to enter the esophagus, which is a part of the alimentary tract. Okay, so the cricopharyngeus or the superior esophageal sphincter has to be closed all the time unless and until we are swallowing some food or some liquid. Only then this cricopharyngeus muscle will be relaxed, right, as a stretch reflex, and it will allow the passage of a bolus of food down to the esophagus. Okay, to understand the arrangement of these constrictors, I believe that you are pretty much able to understand that one constrictor is being covered by the other constrictor, and then the other one is further covered by the other. Okay, but let me show you a makeshift model. They say that imagine the constrictors of pharynx as the lenses of a telescope, the way they have been fitting into each other in a beautiful fashion. So imagine, all right, here it is, and we know that our pharynx doesn't have an anterior wall. Okay, I hope that you're able to understand. So the anterior wall is not there, only the posterolateral wall is present. Okay, and these are the layers of the tube. I have 3 styrofoam glasses, and they are fitting into each other. Okay, so this one is supposed to be, the innermost glass is representing the pharyngobasilar fascia, which is helping the entire pharyngeal tube to dangle down from the occiput or the basi-occiput part of the skull. Okay, so the pharyngobasilar fascia. Then we have this purple cup, which is representing the superior constrictor muscle. Then we have this red cup, which is representing the middle constrictor. So the superior constrictor is partially covering the pharyngobasilar fascia, the lower margin of the pharyngobasilar fascia. The superior constrictor itself is under the cover of the middle constrictor, okay, which is at the level of hyoid, while the middle constrictor itself is covered by the inferior constrictor, which is the outermost cup, okay. It is the topmost, or rather the posteriormost layer of the constrictor muscles, okay. So they fit into each other, and whenever they are contracting, keep in mind that the pharyngobasilar fascia, or the membranous part of the pharynx, never collapses, never contracts, okay. Why? Because it is making the nasopharynx part of the pharynx, and we cannot afford the nasopharynx to be shrunken, to be narrowed down, because it needs to be completely open all the time, even when we are sleeping, when we are eating, because it is the airway, it's a part of the airway, okay? So the rest of the constrictors, when they contract, they are like this, they will contract, okay? So one glass is under the cover of the other glass, and the other glass, and the other glass, so they look like the lenses of a telescope. I hope that you have understood the architecture of the wall of the pharynx, especially the constrictor muscles, okay, how they are arranged. Let me also mention something which is extremely important to know, that here, between the pharyngobasilar fascia and the superior constrictor, the two structures which are emerging, they are entering the nasopharynx part of the pharynx. The first part of the pharynx are the two pharyngotympanic tubes I have mentioned when I was discussing the nose with you guys. The pharyngotympanic tubes are the eustachian tubes, okay? So now look at this specimen once again. I hope that you are able to see, this is our nasopharynx, or the pharyngobasilar fascia, or the membranous part of the pharynx. And you can see over here, with the pencil I have marked the groove which is occupying the cartilaginous part of the eustachian tube, or the pharyngotympanic tube. The name is indicating this tube is connecting the nasopharynx part of the pharynx with the middle ear cavity, which is also known as the tympanic cavity. I hope that you're able to see. The pharyngotympanic tube is residing in this groove, and up here it's opening. So it's opening above the superior constrictor muscles. The gap between the pharyngobasilar fascia and the superior constrictor has been occupied by the two cartilaginous parts of the pharyngotympanic tubes, one on either side, okay? Then there is a slit, there is a gap, a space, it's a potential space, that is present between the middle constrictor, between the superior constrictor and the middle constrictor, like up here in this region, okay? In this region, where the middle and the superior constrictors, where the middle and the superior constrictors are overlapping each other. You know that here is a pointy process which is a part of the temporal bone, the styloid process. So we have a mastoid process and a styloid process. And I just have shown you the stylohyoid ligament, okay? That's a landmark. But here, from the tip of the styloid process, another muscle is taking origin, which is known as the stylopharyngeus muscle, okay? The direction of this muscle would be like this, okay? Sloping downward and medially, okay? It has to go and open into the pharyngeal cavity, right? Oh, it will be blending in the wall of the pharynx. So the stylopharyngeus muscle will be entering the pharynx, or will be blending into the wall of the pharynx. It will be originating from the styloid process and will be passing down through the gap between the superior constrictor, superior constrictor and the middle constrictor. Alright? Along with this muscle, the nerve which is going to supply this muscle will also be entering. That is the ninth cranial nerve, the glossopharyngeal nerve. Right? The glossopharyngeal nerve is predominantly a sensory nerve, sensory cranial nerve, but it has a little motor component. It only supplies one muscle. That is the stylopharyngeus muscle. Okay? Alright. Then through the gap between the middle constrictor and the inferior constrictor, the inferior laryngeal, the superior laryngeal vessels and nerves will be entering. So just like that, we have 3 constrictors of the pharynx. We have 3 elevators of the pharynx as well. So we have the stylopharyngeus, which I just have mentioned, that it takes origin from the styloid process of the base of the skull and then passes down and blends with the lateral wall of the pharynx. Okay, in the musculature of the lateral wall. Whenever the stylopharyngeus will be contracting, it will be pulling the pharynx up, alright, elevating it, lifting it up. Then the salpingopharyngeus muscle, which is, the name is indicating, it's salpinx means a tube, trumpet-like tube, okay? And we know which tube is entering this part of the nasopharynx is the pharyngotympanic tube, which is residing, I hope that you're able to see, let me flip the model, yeah. So in this groove is resting the cartilaginous part of the eustachian or the pharyngotympanic tube. From the inferior margin of the pharyngotympanic tube, the salpingopharyngeus muscle is taking an origin and it travels along with the tube and blends in with the musculature of the superior constrictor or the sides of the lateral wall of the pharynx. What is the function of salpingopharyngeus? It's also an elevator. It lifts up the pharynx, and in this way it just broadens up the opening of the eustachian tube. Whenever we are swallowing something from the mouth, what is happening? The pharynx has been lifted up, and the nasopharynx has been lifted up, and the opening of the pharyngotympanic tube gets broadened up. So it is helping in maintaining or equalizing the pressure of the middle ear cavity when we are swallowing. Okay? That's what happens in case of acute pharyngitis and rhinitis, when there is too much inflammation of the mucosa, that will also cause the inflammation of the pharyngeal end of the pharyngotympanic tube, and then people feel stuffiness in their middle ear or in their ears, and they feel giddy just because of this closure or contraction of the pharyngotympanic opening within the nasopharynx. Okay, so we have another elevator of the pharynx, that is salpingopharyngeus muscle, and the last but not the least is the palatopharyngeus muscle, which is also forming the arch. I hope that you are able to see this model clearly. By the way, this pink color has been added to this model. The white is representing the nasopharynx, the membranous part of the pharynx, while the pink color is representing the oropharynx, because this is the oral cavity that is present between the mandible and the maxilla, and the top part of the oral cavity is the hard palate up here, okay? So the palatopharyngeus muscle is, you can see the sharp border of the hard palate, the posterior border of the hard palate. It gives attachment to the soft palate, okay? So from each side of the soft palate is originating one palatopharyngeus muscle, okay? Now what is happening is, if you focus on this drawing, you can see during swallowing what is happening. the base of the tongue, or the posterior 1/3 of the tongue, it just creates a groove, a gutter. It goes down and then facilitates the bolus of the food to move back towards the oropharynx. And in doing so, what else is happening simultaneously? The soft palate, the palatopharyngeus part of the soft palate, will be contracting, and it's an elevator of pharynx. So what will be happening? It's also not only be elevating the pharynx, but it will also be, it's like this. It will be elevating itself up and closing the nasopharynx. So when we are eating something and we are deglutating, swallowing the food, the passage to the nasopharynx has been blocked by the elevated action of the soft palate. So the soft palate blocks the airway, because I told you that the nasopharynx is the part of, it's the part of airway. It doesn't allow any food particle. It's not a part of alimentary tract at all, like the other two components of the pharynx. So when we start swallowing, the posterior end of the tongue gets depressed, creates a gutter-shaped hollow at the back of the mouth. So the bolus of food travels, it descends, it just slips down towards the oropharynx, and it never goes up, because the soft palate, due to the contraction of the palatopharyngeus muscle, it just got lifted up, okay, and it closes the nasopharynx, entry to the nasopharynx. All right, I hope that you have understood that the pharynx is a fibromuscular tube. The fibrous part of the pharynx is making the majority of the nasopharynx, because it has to be remain open all the time, so it's all membrane. Then the musculature is being categorized into two classifications, that the constrictors of pharynx, which are 3 in number, superior, middle and inferior, and they help propelling the food down. So they depress the pharynx and propel the food bolus down towards the esophagus. While we also have 3 elevators of pharynx. Each of the elevators is originating from one part of the bone which is present in the base of the skull. So we have stylopharyngeus, we have salpingopharyngeus, and we have palatopharyngeus. All of them will be, whenever they will be contracting, they will be lifting up the pharynx. In this way, the pharynx is ready to receive the bolus of the food. Okay, and due to the contraction of the palatopharyngeus muscle, the soft palate is being lifted up and has closed down the entry to the nasopharynx. All right, I hope that you have understood this musculature of the pharynx. Now we will move on to the parts of the pharynx, right? I kept on mentioning during my lecture many times the nasopharynx, oropharynx, and the laryngopharynx. Now I'm going to do it in detail, a little bit more detail. The nasopharynx is the part of the pharynx which is lying just behind the nasal cavity, or it's like a doorway to the posterior nares. It's receiving the inhaled air. All right. It receives the openings of the 2 pharyngotympanic tubes from the middle cavities. It's made up of a membrane or fascia, which is tough and resilient, and it's incollapsible. Okay, so the roof of the nasopharynx, we can say, is the base of the sphenoid body of the sphenoid bone, right? The base, the occiput, and the floor of the nasopharynx is being formed by this, constantly moving soft palate. Okay, so because it is a doorway to the upper airway, so the lining mucosa of the nasopharynx is, strictly speaking, of respiratory type. It's similar to the mucosa of the entire nasal cavity, so except for the olfactory area, of course, we are not touching that region. The pseudostratified ciliated columnar epithelium is lining the nasopharynx. Okay? Then from the base or the oral surface of the soft palate, down till the level of the upper border of the epiglottis, we have the region of the pharynx which is known as oropharynx. It's that part of the pharynx which is visible when you say ah, and it's dangling uvula. Behind the uvula is your sloping down oropharynx. The wall of the oropharynx is visible to you when you are looking in a mirror and you are saying ah. So the oropharynx, which starts from the base of the soft palate, the oral surface of the soft palate, and it just ends at the top part of the epiglottis. It's lining mucosa because the oropharynx is a part of the oral cavity. It's making the posterior wall of the oral cavity, as you can see over here. So the lining mucosa, the epithelial lining of the oropharynx is similar to the lining of the oral cavity as such. So the stratified squamous non-keratinized type of epithelium is lining the oral cavity, and so it is lining the oropharynx part of the pharynx. Okay? Then comes the laryngopharynx. The oropharynx, I have mentioned that it is a passageway for both food and air. It's pretty much different from the nasopharynx, which is strictly for the passage of air. So its lining epithelium is also different. Just like the oropharynx, the laryngopharynx, which is starting from the base of the epiglottis or the lower surface of the epiglottis, and it is lying just behind the larynx, is the laryngopharynx, and it ends at the level of this, posteriorly at the level of the 6th cervical vertebra, and if you look at anteriorly, it is the termination point of the laryngopharynx is the lower border or the inferior border of the cricoid cartilage. Okay, so the laryngopharynx in some books has been mentioned as the hypopharynx or pharynx proper. The mucosa is just like the oropharynx. The laryngopharynx also provides passage for both food and air. The only difference is that when we are breathing all the time. But when we are swallowing something, we are eating, the food has the right of way. Okay? So what will happen? Due to the depression of the posterior 1/3 of tongue, the epiglottis will be depressed and it will be covering up like a lid. It will be covering up the glottis or the laryngeal inlet, and the food will pass down. So the laryngopharynx is also, the mucosal lining of the laryngopharynx is also similar as that of the oropharynx, that is a stratified squamous non-keratinized type. Okay? Before moving on to the blood supply, I want to discuss the innervation. First I will talk about the sensory innervation, and then I will also talk about the motor innervation, which is related to the musculature of the pharynx. So because we are talking about the mucosa, we will first discuss the sensory innervation. The nasopharynx is receiving its sensory innervation from the branches of the trigeminal nerve, the 5th cranial nerve, okay, the maxillary division. While the oropharynx is receiving its sensory innervation, the mucosa of the oropharynx is receiving its sensory innervation. As you can see, it's lying just at the back of the posterior 1/3 of tongue, and we have done with our embryology that the posterior 1/3 is developing from the 3rd pharyngeal arch. The nerve of 3rd pharyngeal arch is the glossopharyngeal or the 9th cranial nerve. So the sensory innervation of the mucosa of oropharynx is coming from the glossopharyngeal or 9th cranial nerve. While the mucosa, the sensory innervation of the mucosa of the laryngopharynx is via the branches of the vagus or the 10th cranial nerve, which is the nerve of the 4th and 6th pharyngeal arches. especially the internal laryngeal branch of the superior laryngeal nerve and the recurrent laryngeal branch of vagus. Okay, so if you remember that the vagus gave off two branches, the superior laryngeal was taking care of the structures of fourth pharyngeal arch, and that includes the pharynx, and the recurrent laryngeal was taking care of the structures derived from the sixth pharyngeal arch. Okay, so the mucosa of the laryngopharynx is receiving its sensory innervation by both the branch of superior laryngeal, that branch is the internal laryngeal nerve, and branches of the recurrent laryngeal also serve the laryngeal mucosa, the mucosa of the laryngopharynx. Okay. As far as the autonomic innervation is concerned, the sympathetic and parasympathetic. So we know that there is a pharyngeal plexus that has been formed by the union of the branches of the vagus, the accessory component of vagus, the 11th cranial nerve component of the vagus, as well as the glossopharyngeal nerve, because I told you in the beginning that glossopharyngeal is predominantly a sensory and parasympathetic nerve, and there is just a little component of motor is present within the glossopharyngeal that is serving the stylopharyngeus muscle. The rest is either sensory or parasympathetic. So the pharyngeal plexus has been formed over the surface of the middle constrictor muscle, and it is up here, and it is formed by the union of the branches of vagus, the accessory component, and the glossopharyngeal. And on sides, you know that there are the sympathetic chain of ganglia. So in the cervical region, the pharynx is located in the cervical region. So the cervical sympathetic ganglia will give off the postganglionic sympathetic fibers. All of them, sympathetic and parasympathetic fibers, will blend together, will give rise to the pharyngeal plexus, and through that pharyngeal plexus, the mucosa of the pharynx is being innervated, and that will take care of the glandular secretion, because the parasympathetic is the secretomotor component of the autonomic system, and also the constriction and dilation of the blood vessels. So the sympathetic component, which is the vasomotor, that will take care of the vasculature. So the secretion, the mucosal secretion of the pharynx is under the control of autonomic nervous system, which is being delivered to the pharynx, the pharyngeal mucosa, via the pharyngeal plexus. Okay, now we move on to the blood supply. As far as the blood supply is concerned, you can see the pharynx is receiving a rich network of blood vessels. Like there is an extensive anastomosis on the surface or the musculature of the pharynx. All right, so it's lying in the head and neck region. So we can easily imagine that the vessels which are supplying the tongue, branches of the external carotid. Keep in mind that most of the branches of the external carotid, which is running like the carotid, the external carotid is running in the column of neck, and it's giving off 8 branches. Most of the branches are supplying the extracranial structures. In fact, none of them is going inside the cranial cavity. So take the example of the lingual artery, which is a direct branch from the external carotid, that is also giving off branches to the pharynx. The facial artery, another direct branch from the external carotid, is serving the pharynx, along with the main branch as well as the tonsillar branch. Okay, there are tonsils, palatine tonsils present on either side of the soft palate. So the tonsillar artery will also be contributing into the blood supply. Then there is an ascending pharyngeal branch of the external carotid that will also be contributing into the blood supply of the pharynx. And also the superior and inferior laryngeal arteries. Okay, so there is a huge anastomosis among these branches of the external carotid and the subclavian system. Okay, what about the venous drainage? In this other drawing, you can see that at the back of this is the posterior surface of the wall of pharynx, and we can see over the constrictor muscles is lying like a humongous elongated plexus of veins. Okay, this is the pharyngeal plexus of veins. There is a pharyngeal plexus of nerves, which is actually the autonomic plexus, okay, which I just have discussed, that is present within the pharyngeal cavity over the mucosa. Okay, while this pharyngeal plexus of veins is present at the back wall of the pharynx. Okay, so you can see the top part of the pharynx, the top part of the pharyngeal plexus is ultimately dumping its blood into the pterygoid plexus of veins, which is present here in the region of the lateral pterygoid muscle. Okay, and then we know that the pterygoid plexus is also communicating with the cavernous sinus. All right. The middle part of the major portion, or the middle part of the pharynx, the plexus is draining into the internal jugular vein, the IJV. Okay, the internal jugular vein is receiving the middle part venous blood of the pharynx, while the inferior-most region of the pharynx, which is close to the esophagus, is the plexus is draining directly into the brachiocephalic vein, which is the union of the internal jugular vein and the subclavian vein. So the pharyngeal plexus of veins, which is a huge plexus, is present on the entire length of the back wall of the pharynx, is draining into 3 channels. The top part is draining into the pterygoid plexus. The middle part is draining into the internal jugular vein, which is up here. The inferior-most part is draining into the brachiocephalic vein. Okay, so this is the blood, the blood supply, the arterial supply, and the venous drainage. The collection of the huge collection of lymphoid tissue we are having in this region. So here in front of you there is a drawing showing us the inside of the oral cavity. Well, you can see this is the anterior 2/3 of the tongue and the posterior 1/3 of the tongue, which is making the floor of the oral cavity. The top of the oral cavity is being formed by the hard palate, and at the back, at the very back, it would be the soft palate. Okay, so these 2 arches are the part of the soft palate. Keep in mind. Okay, because the hard palate is not visible in this drawing. All we can see is when you say ah in front of the mirror, you are able to see your tongue in the floor, and at the top you can see something which is dangling at the back. In the middle is the uvula, which is this one, and on the sides are the 2 arches. Okay, so you can see the outer one, which is emerging from the soft palate and blending in on the sides of the tongue, are the 2 palatoglossal arches. Okay, they are also known as fosses. Okay, palatoglossal fosses. So we have 2 of them, a pair on each side, one on each side. So we have a pair. Then the inner one, because this part, keep in mind, is actually the hanging down oropharynx. Okay, which is visible from the oral cavity. Okay, at the back of the oral cavity. So these are the arches which are known as the palatopharyngeal arches. Okay, they are going down into the pharynx. Remember, I told you that the palatopharyngeal muscles, which are making these arches, the mucosal arches, the foldings which have the palatopharyngeal muscles, they will be going down into the lateral walls of the pharynx, and they will be blending into the musculature. Okay, so together these palatoglossal and palatopharyngeal arches or fosses are also known as fascial pillars. Okay, so we have an anterior fascial pillar which is made by the palatoglossal arch, and we have a posterior fascial pillar, which is made by the palatopharyngeal arch. Okay, these are the mucosal enfoldings, right? In between these fascial pillars, at the very back of the tongue, you call it the root of the tongue or the posterior 1/3 of the tongue, on each side we have a set of tonsils. They are known as the palatine tonsils because they are located in the walls of the soft palate at the very back of the tongue. Then in the middle we have another collection of the lymphoid tissue, which is known as the lingual tonsil because it's located on the back surface of the tongue. Then on top, if you remember from the knowledge of your nasopharynx, then that on either side in the walls of the nasopharynx are opening the two pharyngotympanic tubes or the eustachian tubes. Remember, I told you that each tube, the opening of each tube is like a comma shape, and it's been covered by a collection of lymphoid tissue. They form the tubal tonsils. They are known as the tubal tonsils. So we have a set of tubal tonsils, a set of palatine tonsils in the fascial pillars of the soft palate. There is in the center, at the base of the tongue, we have the lingual tonsil, right? And then if you remember at the top where the nasopharynx is taking its origin in the roof of the nasopharynx, just behind the posterior nares, we have a cluster or collection of lymphoid tissue that is known as the nasopharyngeal tonsil. This nasopharyngeal tonsil, when it gets enlarged, it gets inflamed, it's also known as adenoid. Okay? So commonly they are known as adenoids. A child is suffering from adenoids, right? He's having adenoids, enlarged nasopharyngeal tonsil. And you can imagine if the nasopharyngeal tonsil will get inflamed, what can happen, right? It will be obstructing the posterior nares or the choanae, and the child will be suffering from obstruction in breathing, especially at night when he will try to sleep in supine position. He won't be able to sleep properly. He'll snore a lot, and the mother will complain that the child snores all the time, and he'll try to breathe through mouth, so he'll sleep with an open mouth because the posterior choanae or the entrance to the nasopharynx is being blocked by the inflamed nasopharyngeal tonsil, which are now known as adenoids. Okay? Now if you look at this collection, it's making somewhat a ring like this. Okay? At the, this is the opening, posterior opening of the nasal cavity, through which we are breathing in air and breathing air out, breathing in, breathing out. So the nasal cavities are connecting the external environment with the internal environment or internal milieu of our body. Okay? Same is the case with the oral cavity. We are connected through the oral cavity with the external environment. So this ring of lymphoid tissue, which is known as the Waldier's ring or Waldier's ring of lymphoid tissue, it's providing the first line of defense against the invaders which enter through the nasal passage as well as the oral passage. Okay, so we know that the lymphoid tissue is the component of the immune system. So we offer the first line of defense through this Waldier's ring. Okay,